Primary pulmonary hypertension. Primary pulmonary hypertension, PPH, is defined as a sustained elevation of pulmonary artery pressure, PAP, to a mean of more than 25 mmHg at rest or 30 mmHg with exercise, in the absence of a demonstrable cause. Recent developments have highlighted that there is some overlap between primary and secondary pulmonary hypertension in their histological features and response to treatment. The latest WHO classification uses 5 groups defined by their mechanism. Table 38. Etiology, pathophysiology, and pathology. The etiology is unknown, but the following have been suggested. Genetic. 10% of cases are familial, localized to chromosome 2, with autosomal dominant inheritance. Autoimmune, associated with a number of collagen vascular disorders. Infection, human herpes virus 8 causes Kaposi's sarcoma. Pulmonary vascular endothelial dysfunction. Increased pulmonary vascular resistance is produced by vasoconstriction, vascular wall remodeling, medial hypertrophy and smooth muscle, thrombosis in situ. This results in right ventricular hypertrophy and then failure, as a result of the increased afterload. Epidemiology. Incidence is about 1 per million per year, but the use of appetite suppressants is associated with a greater than 20-fold increased risk. The female-to-male ratio is 2 to 1, with most diagnoses made in the 4th decade. Clinical presentation. Early symptoms of PPH are nonspecific. Common. Exertional dyspnea. Fatigue. Angina, right ventricular ischemia. Syncope and presyncope, especially exertional. Uncommon. Peripheral edema. Raynaud's phenomenon, mostly in women. Hemoptysis. Physical signs. Left parasternal heave. Loud P2, pulmonary component of second heart sound. S4 originating from the right ventricle, pressure overload. Pansystolic murmur, prominent jugular V waves and pulsatile liver of tricuspid regurgitation. Peripheral edema and elevated JVP of right ventricular failure. NB. Clubbing is not a feature of PPH and, if present, may indicate lung disease or cyanotic congenital heart disease as the underlying cause of the pulmonary hypertension. Investigations. The following investigations are used to confirm pulmonary hypertension, determine prognosis, and guide therapy. Echocardiography. Demonstration of dilated and/or hypertrophied right heart, Fig 84. Measurement of PAP. Exclusion of shunts and valvular and left ventricular abnormalities. A transesophageal study may be necessary to distinguish an atrial septal defect. ECG. Look for Fig 85. Tall P waves. Right axis deviation. Right ventricular hypertrophy. Chest radiograph. Look for prominent pulmonary arteries with peripheral pruning, and for features of underlying lung disease. Fig 86. Cardiac catheterization. Measures pressures and saturations, prognosis and shunt calculation, and assesses response to acute vasodilators such as prostacyclin, adenosine, or inhaled nitric oxide. Investigations to exclude secondary causes. Blood, FBC, for secondary polycythemia, liver function tests, erythrocyte sedimentation rate, rheumatoid factor, and autoantibody screen, and consider an HIV test. Pulmonary function tests, to exclude obstructive or restrictive lung disease. Sleep study, if there is suspicion of obstructive sleep apnea. Exclusion of pulmonary thromboembolism by ventilation perfusion scan, spiral CT scan of the chest with contrast, or pulmonary angiography, Fig. 87. NB. Consider the following in your differential diagnosis. Secondary pulmonary hypertension. Left ventricular outflow tract obstruction. Ischemic heart disease. Treatment. Anticoagulation. Diuretics with daily weight checks to avoid excessive fluid depletion. Oxygen for hypoxemia. High-dose calcium channel blockers in those patients who have a significant fall in pulmonary vascular resistance on acute vasodilator testing. In patients who fail to respond to acute vasodilator therapy and have a poor functional class, the following should be considered. Endothelin antagonists, bosentan, monitoring of liver function tests is needed. Prostacyclin analogs, intravenous or nebulous prostacyclin therapy. Phosphodiesterase type 5 antagonists, sildenafil. Atrial septostomy to decompress the right ventricle and improve left-sided filling pressures. Lung or heart-lung transplantation in those who fail to respond to any other treatment. Prognosis. Survival depends on right ventricular function. Overall, the 5-year survival rate is 20%, but the subgroup with adverse hemodynamics has a 20% 3-year survival rate. Responders to chronic calcium channel blocker therapy have a 95% 5-year survival rate. Anticoagulation, prostacyclin, and heart-lung transplantation, 5-year survival rate of 50–60%, all confer a survival benefit. Bosentan and sildenafil have been shown to improve hemodynamics and exercise capacity. NB. Important information for patients. Strongly advise against pregnancy. Avoid the oral contraceptive pill if possible. It may exacerbate pulmonary hypertension.